This is Lecture 11, Trauma, Massive Transfusion, and Hemorrhage Control. The ED job is to find what kills first using the primary survey, resuscitate with blood not crystalloid, control hemorrhage with mechanical and pharmacologic tools, and avoid the lethal triad of hypothermia, acidosis, and coagulopathy. Crystalloid is the wrong answer in hemorrhagic shock. The objectives are these. First, run the primary and secondary survey efficiently. Second, recognize and treat hemorrhagic shock with balanced blood products. Third, activate and run massive transfusion protocol. Fourth, use tranexamic acid in the appropriate window. Fifth, recognize and treat immediate thoracic killers. Sixth, manage pelvic and extremity hemorrhage. Seventh, manage head trauma with attention to secondary injury. And eighth, avoid the classic trauma board traps. The ED trauma mindset is find what kills first. The primary survey is a sequence designed to identify and treat immediate life threats in order: airway with cervical spine protection, breathing, circulation, disability, exposure. Resuscitate with blood when there is significant hemorrhage. The lethal triad is hypothermia, acidosis, and coagulopathy. Prevent it. Crystalloid alone is bridging. Definitive resuscitation is blood plus mechanical hemorrhage control. The primary survey is ABCDE. A is airway with cervical spine protection. Assess patency. Protect the cervical spine with a collar or manual stabilization. B is breathing. Look for asymmetric chest movement, tracheal deviation, decreased breath sounds, paradoxical movement. C is circulation. Check pulses, blood pressure, look for external hemorrhage, large bore IV or intraosseous access, type and cross-match. D is disability, GCS, pupils, gross motor exam, glucose. E is exposure. Completely undress the patient, log roll, and warm. This is a sequence designed to find what kills now, not a documentation checklist. Hemorrhagic shock has a pattern. Tachycardia and narrowed pulse pressure precede frank hypotension. Young patients compensate until they crash. The shock index, heart rate over systolic blood pressure, greater than 0.8 predicts the need for transfusion. Look for bleeding in the 5 potential spaces: chest, abdomen, retroperitoneum or pelvis, long bones, femur fractures lose up to 1.5 liters, and external. The board concept is that normotensive does not mean not bleeding. Mental status, skin perfusion, urine output, and pulse pressure are earlier than blood pressure. Hemorrhage is the most common preventable cause of trauma death. Trauma mortality follows a bimodal curve: immediate deaths from massive injury, then early deaths from hemorrhage in the first hours. Massive transfusion protocol is a system intervention. Activate early when significant hemorrhage is anticipated. Triggers include shock index over 1, ABC score of 2 or greater, ongoing hemorrhage despite initial resuscitation, or clinical judgment. Know the ABC score for the boards. 1 point each for penetrating mechanism, systolic blood pressure under 90, heart rate over 120, and positive fast. 2 or more points means activate. The 1:1:1 ratio was validated by the proper trial. Use balanced blood products, packed red blood cells, fresh frozen plasma, and platelets in a 1:1:1 ratio. Avoid crystalloid heavy resuscitation, which causes dilutional coagulopathy. Replace calcium during large volume transfusion, either chloride 1 gram or gluconate 3 grams intravenously per 4 units of blood. Prevent hypothermia with warm fluids, warm blankets, and forced air warming. Address acidosis. Reassess frequently, and definitive hemorrhage control is the goal. Tranexamic acid is time-sensitive in trauma. The CRASH 2 trial showed mortality reduction when given within 3 hours of injury. Standard dosing is 1 gram intravenous over 10 minutes, followed by 1 gram over the next 8 hours. TXA does not replace blood or definitive hemorrhage control. It complements them. Give TXA in trauma patients with significant hemorrhage or ongoing bleeding within the 3-hour window. The board trap is delaying TXA or giving it outside the window. Imaging in trauma depends on stability. The unstable patient does not belong in CT. The FAST exam, focused assessment with sonography for trauma, evaluates 4 windows. Right upper quadrant for Morrison's pouch, the hepatorenal recess. Left upper quadrant for the splenorenal recess. Suprapubic for the rectovesical space or pouch of Douglas. And subxiphoid for the pericardium. The extended FAST or EFAST adds bilateral anterior chest assessment for pneumothorax and pleural fluid. A positive scan in a hypotensive patient sends them to the OR. A negative one does not exclude all bleeding. Retroperitoneal hemorrhage, intracranial. The stable patient gets structured CT-based injury definition. The board concept is that the unstable hemorrhaging patient needs the OR, not the scanner. Chest trauma has 5 immediate killers. Find them in the primary survey: tension, pneumothorax, hypotension, decreased breath sounds, deviated trachea late, immediate needle decompression at the second intercostal space, mid-clavicular, or the fourth to fifth space anterior axillary line. Follow with tube thoracostomy, open chest wound, the sucking type, three-sided occlusive dressing, then chest tube, massive hemothorax, greater than 1,500 milliliters of initial drainage or ongoing 200 milliliters per hour for 2 to 4 hours. That is the thoracotomy threshold. Chest tube, blood transfusion, surgical consultation, cardiac tamponade, Beck's triad of hypotension, muffled heart sounds, and JVD. The boards know all three are present in fewer than half of cases, so do not wait for the complete triad. Subxiphoid fast is the test of choice. Pericardiocentesis or pericardial window in unstable patients. Flail chest, paradoxical chest movement with underlying pulmonary contusion, supportive care, oxygen, possibly intubation. Pelvic fractures can hemorrhage massively from the venous plexus and arterial sources. Apply a pelvic binder at the greater trochanters, not the iliac crest. That landmark is the wide point of the ring where binding provides maximum compression. Internal rotation of the legs helps close it. Arterial injury to an extremity can be life-threatening. Direct pressure first. Tourniquets are life-saving for proximal limb bleeding. Place the device 2 to 3 inches above the wound. Tighten until bleeding stops. Document time of placement. Open fractures get antibiotics, cefazolin within 1 hour, tetanus update, and orthopedic involvement. The board concept is that mechanical hemorrhage control is the resuscitation. The pelvic binder goes on before angiography or the operating room in the unstable pelvis. REBOA, resuscitative endovascular balloon occlusion of the aorta, is an emerging option for non-compressible torso hemorrhage as a bridge to definitive control. Head trauma resuscitation prevents secondary injury. The cardinal rule is avoid hypoxia and avoid hypotension. Each episode of hypotension below 90 systolic doubles mortality in severe TBI. The current target is a systolic of at least 110 in those patients. Permissive hypotension does not apply to head-injured patients. Watch for Cushing's reflex, hypertension, bradycardia, and irregular respirations. That is a late sign of elevated intracranial pressure. Each desaturation worsens outcome. Reverse anticoagulation aggressively when intracranial hemorrhage is present. Manage rising ICP with head elevation. Mannitol 1 gram per kilogram or hypertonic saline 3%, 250 milliliters bolus or 23.4% 30 milliliters via central line. Maintain serum sodium 145 to 155. Call neurosurgery early for evacuation candidates. Treat seizures if present. The lethal triad of trauma is hypothermia, acidosis, and coagulopathy. Each worsens the others. Hypothermia impairs coagulation enzyme function. Acidosis impairs platelet function. Coagulopathy causes bleeding, which worsens shock, which worsens both. Prevent. Warm products, warm patient. Prevent dilutional resuscitation. Address acidosis. Damage control resuscitation is hemostatic resuscitation. Balance products. Permissive hypotension targeting a systolic of 80 to 90 in penetrating trauma without head injury until surgical control. Limiting crystalloid and damage control surgery. Abbreviated operation focusing on hemorrhage and contamination control with later definitive surgery. The board concept is that the lethal triad is preventable and prevention saves lives. Trauma in pregnancy is 2 patients. Resuscitate the mother to save the fetus. Left lateral tilt of the backboard 15 to 30 degrees relieves aortic valve compression from the gravid uterus. Maternal oxygen, fluids, and blood products are the priority. Anti-RHD immunoglobulin, ROGAM, for Rh-negative mothers after significant trauma. Fetal monitoring for at least 4 to 6 hours, longer if there is concern. Perimortem cesarean delivery within 4 minutes of maternal arrest if gestational age is greater than 23 weeks, fundus above the umbilicus. The board concept is that maternal resuscitation is fetal resuscitation. The trauma board traps are predictable. Sending the unstable hemorrhaging patient to CT instead of the OR, placing the pelvic binder too high at the iliac crest instead of greater trochanters, crystalloid-only resuscitation in hemorrhagic shock, forgetting calcium during massive transfusion, missing tension pneumothorax before intubation, where positive pressure can convert simple to tension pneumothorax, allowing hypothermia to worsen coagulopathy, delaying TXA past the 3-hour window, failing to reverse anticoagulation and head trauma with intracranial hemorrhage, and missing the second patient in trauma and pregnancy. The CT scanner is the wrong destination for the unstable patient. Case 1. A 28-year-old after a high-speed motor vehicle collision is hypotensive at 85/50 with diffuse abdominal tenderness. FAST is positive for free fluid in the right upper quadrant. This is a surgical patient. Activate massive transfusion protocol. Give blood, not crystalloid. Consider TXA if within 3 hours of injury. Replace calcium. Warm the patient. Go to the operating room with trauma surgery. The board trap is delaying hemorrhage control for CT imaging. Case 2. A high-energy trauma patient is hypotensive with pelvic instability on exam. Place a pelvic binder at the greater trochanters with internal rotation of the legs. Activate massive transfusion protocol. Replace calcium with calcium chloride 1 gram or calcium gluconate 3 grams per 4 units of blood. Warm aggressively. Coordinate interventional radiology for angioembolization or operating room for surgical control based on response and institutional pathway. The board trap is the binder at the wrong location, providing inadequate compression. Question 1. An unstable blunt trauma patient has a positive FAST and continued hypotension despite initial blood. What is the next best step? The answer is operating room with trauma surgery. The unstable hemorrhaging patient does not belong in the CT scanner. The trap is imaging an unstable patient. Question 2. During ongoing massive transfusion, a patient becomes hypotensive with new arrhythmias. What electrolyte concern do you address? The answer is hypocalcemia from citrate-based anticoagulant in blood products. Give calcium chloride 1 gram intravenously or calcium gluconate 3 grams intravenously per 4 units of blood transfused. The trap is for getting calcium replacement. Question 3. A patient with a suspected pelvic fracture needs a pelvic binder. What is the correct location? The answer is at the level of the greater trochanters. The greater trochanters are the wide point of the pelvis, where binding provides maximum ring compression. The trap is placing the binder around the abdomen or iliac crest. The final takeaways are these. Find what kills first using the primary survey. Hemorrhagic shock requires blood, not crystalloid. Activate massive transfusion protocol early. Use balanced products at 1:1:1. Give TXA within 3 hours of injury. Replace calcium during massive transfusion. Prevent hypothermia. Tension pneumothorax requires immediate needle decompression. Massive hemothorax goes to the OR. Pelvic binder at the greater trochanters. Tourniquets save lives in extremity hemorrhage. Avoid hypoxia and hypotension in head trauma. Trauma in pregnancy is 2 patients, and maternal resuscitation is fetal resuscitation. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the Advanced Trauma Life Support, ATLS, 10th edition, the CRASH 2 trial for TXA, the proper trial for balanced transfusion ratios, the Tactical Combat Casualty Care Guidelines for tourniquets, the American College of Surgeons Trauma Practice Management Guidelines, and ACOG resources for trauma in pregnancy. Local trauma center protocols, massive transfusion activation criteria, and damage control resuscitation pathways guide site-specific decisions.